Hi, everyone. Welcome to Thursday VMR. I am so excited to be back. I have been suffering from an acute case of Thursday VMR deficiency. I'm happy to report it's getting a lot better acutely. So thank you so much for joining us. I'm super excited to discuss today with the one and only Robbie M.G. Ha, Dr. Robbie M.G. Ha. But we need you all. So we would love to have a case presenter, and we would love to have two discussants to talk medicine and have fun. And before I pass on mic to RG to reflect on some medicine, I wanted to do two things. One, I wanted to give a personal shout out to my dad. So my dad follows VMR and CP solvers religiously, even though he's not in medicine. So for the last few Thursdays, he kept texting me being like, "You were not on VMR." So I'm sorry to disappoint Dad, but I'm back. Hey, Baba. And he's the best girl dad before there were any girl dads. So thank you for all the support. And I wanted to shout out for July 1st. I am so excited for all the transitions that is happening. I woke up this morning and just started texting people, our ones who are R2s who are becoming third-year residents who are fellows and attending. And it's such a, like, change is hard, but change is also good. So I just wanted to say to everybody who is going through a next phase of life that you got this. It's hard things are also good things, and I would also, my only suggestion to do is always have space for the things that you love doing outside medicine, because that what brings us joy as humans. And don't forget to build those communities and friendships and relationships in new places. And that what sustained me throughout residency. So RG, what did we learn in VMR yesterday?
Hello, Mr. Shikarcham. How are you today? I feel like in all my talking, I'm just going to address your dad, okay? Like as if he's the only person I'm talking to. And I want him to feel, I want to apologize for not acknowledging him for every single VMR that he's been part of, because he has been clearly.
He might give you some feedback afterwards. I just want you to be ready.
Oh, yes, I would love that. I would love that. Yeah, I just, as soon as you said that, I'm like, wow, there's like somebody watching me that I don't even know is watching me, who knows me, but doesn't really know me, who I know of, but I don't really know, it was a weird feeling. But yes, happy July 1st to everybody. It's an amazing day. In many ways, part of the hitting the reset button, in many ways, part of the move on button. And I think in many ways, it's a joy for people who've been through a very tough year for many reasons, allowing them to reset, recalibrate, and move on. Not move on, but grow, and allow people to jump in and to the most humbling and fulfilling and challenging profession that I can think of, even though that seems like self-flattery. It has some truth to it. Yesterday, we had an incredibly educational case. Truly, I think it's not just educational because it highlights some very important principles of clinical reasoning, but it's educational because it could happen to you so easily. And it's actually not happened to me directly, but I've actually can remember 2 or 3 cases where I was either around or heard of a similar concept. Here's the core lesion. The core lesion was yesterday. We had a patient who was immunocompromised because of cancer who developed yeast in her blood. So if I tell you that, I'd love for the chat to think alongside me. So if a patient has yeast in the blood, what could it be? And I'll pause for 30 seconds. I'll allow you to answer that question and also consider presenting a case or discussing. All right, so 30 seconds. Tell us if you have a case and tell us what you think about yeast in the blood. Fatima, do you want to unmute and tell us more about your thought? If you can. If not, just tell us in the chat that you can unmute. That's okay. No worries at all. Rafa, what are you thinking?
Oh, I'm thinking about candidemia.
Amazing. And when you say candidemia, what do you think of? Who gets candidemia?
Immunocompromised patients.
Wonderful. There's a variety. There's a variety of immunocompromising conditions that result in candidemia. Some of them are subtle. Some of them are like TPN, bowel surgery, so on and so forth. But yes, the question is, why do you get yeast in blood? And one reason is that you have Candida in the blood. Why else would you have yeast? What other yeasts can you find in the blood? I'll pause for another 30 seconds. And please, please, please jump in if you have a case. But the question is, what kinds of yeast can exist in the blood / grow on the blood? Kushal, teach us.
Hi, everyone. Yeah, so the other fungi that can grow in the blood would be Melissasia furfur, which would happen with parenteral nutrition, central lines, and Fusarium, which we'll see in transplant patient, neutropenic patients, or hematologic malignancies. And you can even see like necrotic ulcers, which kind of looks like ecthyma gangrenosum with Fusarium. Yeah, those are the ones that I think about usually that quickly grows in the blood. And trichosporin as well. Trichosporin. The part about trichosporin is it causes false positive cryptococcal antigen. So that would be something to watch out for.
Absolutely love that list. Super, super helpful as per usual. And then the final addition I will tell you that was the answer yesterday is sometimes you can get a true positive cryptococcal antigen. And sometimes the burden of cryptococcus is so high in the blood that you can actually culture it and grow it in blood medium. And you'll see, if you've ever seen Candida before grow on blood cultures, what a lot of microbiology labs report is they say yeast in the blood, and they'll tell you specifically, because they'll do some tests for crypto, yeast, not crypto. And that's crucial because the differential diagnosis of yeast in the blood is extensive, no different than the differential diagnosis of gram-positive cocci in clusters is extensive. We think about Staph aureus, coagulated staph, so on and so forth. So when you get a result of blood cultures showing yeast, you have to stop back and say, is it Candida or is it other yeast? And unfortunately, yesterday, it turned out not to be Candida. It turned out to be another yeast, Cryptococcus, and that patient developed a headache and personality changes and was ultimately also found to have a lymphocytic pleocytosis in CSF, and that's how they were diagnosed with Cryptococcus. But for weeks, they went undiagnosed with Cryptococcus in the blood, which was presumed to be Candida. Now, not only is there a diagnostic error being made there, but there's an important pearl to know. The empiric treatment of candidemia or Candida in the blood is an echinocandin, so things like caspofungin and mycofungin. Any guesses as to how well those medications work for crypto? The answer could be 0 or 0 or 0. And the answer is in fact 0 because they do not work. Cryptococcus is intrinsically resistant to echinocandins, which is why you see the therapy bridge azoles and amphotericin without ever hearing mycofungin or caspofungin. So the biggest takeaway from yesterday is to recognize that there is a DDX for yeast in the blood, no different than there is a DDX for gram-positive cocci in the blood. And it's almost always going to be Candida, but almost is always a humbling reminder in medicine because you will come across that exception when it's actually Cryptococcus and not Candida. So always follow up that blood culture result and always consider the DDX before you move forward. One other humbling reminder, the other final humbling reminder is how devastating Cryptococcus can be to the brain and how long and hard the treatment can be. So yesterday's case, the patient I learned later actually required a lot of, suffered a long protracted course of intrathecal focused treatment for Cryptococcus, which I'll finally embed to say Cryptococcus just loves the brain. So anytime you have a meningoencephalitis, you just have to think about it. So to summarize, yeast in the blood, Candida, crypto, or many others, like Kushal reminded us. And if you have a meningoencephalitis, you have to think about Cryptococcus no matter what. And that was the medicine we learned yesterday, and I'm excited for the learning coming our way today.
Thanks so much, RJ, for that. What a humbling case. And whoever presented that case yesterday, thank you. What I love about like kind of morning report VMR is that like we get to learn from cases, and now we are all better equipped to treat a patient who comes in and manage and evaluate a patient who comes in with yeast. We had a case of candidemia last week on service, and thankfully it turned out to be Candida glabrata, but again, a humble reminder not to think about other yeast, because I didn't. I thought only about Candida. So thank you for that. Rafa is willing to present a case. Yay! But we need 2 discussants. Anybody wants to chat about medicine with us today? I'm just gonna have an awkward smile for the rest of the time.
Your dad should join us. You should call him. Just tell him to come hop on and join and talk some medicine.
Start like calling out names. It is July 1st, so I feel like we shouldn't put people too much on spot on July 1st at least. That's a July 2nd thing.
Simone knows that I would totally pick on her, but I just know she finished a night shift. So that's why she has her video off and she's able to chill.
I would let you pick on me, but I'm still walking into my house from work. Otherwise, I would let you pick on me.
Yeah, Simone, you're awesome. Congrats on being done with your first shift as an R2. Woohoo! All right. RG, do you want to just rock and roll, or should we give people?
I would be honored on your return to VMR to rock and roll.
Sounds good. I'm glad you're going to be there to smooth my rustiness. Rafa, whenever you're ready, let's just rock and roll. And maybe we can just amplify people on chat when they have amazing things that they want to share.
Okay, so this is a case by Mary J. Flesh from Whale Corner Medical College. The chief complaint is painless lesion on the right oropharynx. And that's the end of the quote.
All right. I can start, and then I'll pass the mic immediately to Robbie. It's going to be great. So I think when it comes to the painless lesions, the question becomes, how was that painless lesion even identified, right? Most often that when we have any lesions and patients come in is because somehow they identify. So I'm actually curious to know, because a lot of the time it tends to be more painful. I think like a little bit of a history surrounding about how this was identified in the beginning would be helpful. And I think in terms of like lesions in the oropharynx, the differential remains broad, like thinking about like your infectious etiologies, malignancy, autoimmune, although they tend to be more painful in my experience. Like, you know, from autoimmunes, your Sjogren's type, from, you know, Behçet's, those things, but again, that tend to be painful. So I don't know if I have an extensive differential for the painless lesions. I'm always open to the possibility that there are some variation with the patients that are manifesting about how they're perceiving pain, and additionally about what accompanies those oropharynx lesion. Because it's a case in a VMR, I know there's going to be more to it. RG, I can't wait to learn from you.
Oh, I don't think I'll be able to teach you anything. And I think that's probably what would happen in real life. Like, okay, if I see a painless lesion in the oropharynx, I think there are two ways to approach it. I think a dermatologist and an expert would be able to be like, look at that 90-degree bend and look at that color shift and look at how deep it is and be like, aha. But that's not how an internist is, I think, equipped to solve this problem. An internist steps back and says, I know the whole body better than I know this lesion. So tell me the context and I will tell you how I'll make progress. So the first step is to recognize that the oropharynx is part of a system. And that system is the mucocutaneous system. And the key question is there, let's understand the nature of the problem. The patient directed us, or somebody, somehow the spotlight is being shown on a painless lesion in the oropharynx. But to understand the nature of this lesion, you have to understand the nature of the system in which it exists. It's no different than if somebody comes in and they're anemic. Your first question, and if you listen to the most recent RLR, very humbling case, the first question was, what is the white blood cell and what is the platelet count? And those will profoundly influence the differential diagnosis. So if there's an extensive rash along with this, very different than just this. And so I guess the question is, what is the mucocutaneous system itself? It's the skin, it's the oropharynx, it's the eyes, it's the nose, it's the genital mucosa, but most importantly, I'd encourage you to think about the GI mucosa as an extension of the oropharynx. Could this be Crohn's disease with oral ulcer manifestation? So I'm immediately interested in understanding the nature of this problem, studying the skin, the other mucosa, and any clues to point to GI tract involvement, be it on exam, with history, or even with labs to suggest microcytic anemia, for example. And after we do that, then we study, I think, the lay of the land elsewhere. Are there other systems involved? And I don't think I can look at something in the oropharynx, apart from maybe Kaposi's sarcoma, which has a characteristic purplish hue, or a necrotic dark eschar that looks like mucor, to be able to be like, I know what, or Canada. I think Canada is probably more evident. But there's a short list of things you look at, you're like, but more, you're going to be much wiser by studying the mucocutaneous system, which again is skin, mucosa, and GI tract, and then also study other systems involved before we make progress. So, Sharmi, what did I just say? I said nothing. I said I'm not gonna study this. I'm gonna study everything else.
That was brilliant. Sure, you didn't say anything at all. I love that, Robbie. I love like thinking about the mucocutaneous and also not forgetting the GI tract. That's fantastic. Rafa, we can't wait to hear more.
Okay, so this is a 45-year-old male that came for his 3-month follow-up for pre-exposure HIV prophylaxis. This patient had been sexually active with more than one partner. He infrequently performed anal insertive but never receptive intercourse. He felt well overall, but had a new painless lesion on the right oropharynx. And on the review of systems, this patient denies fever, denies weight loss or night sweats. No genital lesions or discharge. No headaches. No cough or dyspnea. This patient noticed a non-pruritic rash across his torso and back that started a few days prior. Non-pruritic rash across his torso and back. And he was seen by urgent care and treated for an allergy with IM steroids with improvement. The rash returned. And this patient was seen by derm and diagnosed as pityriasis rosacea and given topical steroids, but he hasn't started them yet. When it comes to past medical history, this patient had asthma, fatty liver, GERD. He had EGD in the past with fundoplication 2 times. His mother had cervical cancer and his father had hyperlipidemia. This patient just denies smoking, alcohol or illicit drug use. And medications that he's on antricitabine, tenofovir, disoproxil, fumarate. And that's the end of the aliquot. I'm sorry if I butchered all those English terms.
You should apologize for apologizing, but I'll call you afterwards and reflect on that apology. That's the only thing you should apologize for. Maybe I can just reflect on what we learned about HIV prophylaxis and the background medical history, and leave the lay of the land for Charmaine to study. And I think I just wanted to put in a plug for pre-exposure prophylaxis for HIV. It is a highly effective method with astounding numbers in terms of reducing the incidence of new HIV infection. And the regimen is simple. It's often 2 drugs with very minimal toxicities. You'll often hear about tenofovir, which is a backbone of PrEP or pre-exposure prophylaxis, causing kidney injury, but that with the newer formulation of tenofovir is less and less likely. And a plug for a podcast named Febrile, which is an ID podcast based out of Boston, has an amazing episode on pre-exposure prophylaxis that I was listening to, but in the middle of listening to it, I was visited by a friend I didn't want to be visited by. Namely, there were flashing lights behind my car as a police officer approached me, and I'll leave the details, the rest of the conversation, not to public knowledge, but it ended well, I will tell you. So I am that episode is currently on pause, abruptly terminated by an event that thankfully ended well. But yeah, anyway, so this is where I go into TMI, and I'm reeling myself back in. But anyway, check that out. It's a really good febrile episode. Okay, and then the thing to know about pre-exposure prophylaxis is that it really does not at all affect the incidence of other sexually transmitted infections. It is really HIV focused pre-exposure prophylaxis. So you have to discuss with your patients that the risk of other sexually transmitted infections is not modified whatsoever. And I think if you look at the background of asthma, fatty liver disease, GERD, I think anytime that a patient with asthma gets a rash, you have to entertain the possibility that's atopic in nature, because asthma, while it's a very mild risk factor for atopic disease, the rate of eczema and other atopic conditions is minimally elevated in patients with asthma. So here, if you emphasize the asthma as a background, you'd come to a pruritic rash as possibly being atopic in nature. But I wanted to say that background only modifies the foreground a little bit. Most patients with asthma are not markedly atopic, but I think with this patient being on pre-exposure prophylaxis, if they're taking it, there's pretty good efficacy against HIV, but not any efficacy against other sexually transmitted infections. And the background of asthma makes atopic disease plausible, but doesn't elevate the risk too much. I'll pass the mic to Charmaine.
I'm just really, really glad that episode ended well. RG, I can't wait to hear more. Thank you so much. I can't wait to check out that episode of Febrile. And I think RJ is spot on. And I think like we have a bit more information to build on now. In a setting of someone who is coming in, I think making sure that he's taking that HIV prophylaxis and also just taking a better health-related behavior and sexual history. Is there any oral, anal sex that is going on? And I think like it's on us to be more comfortable asking these questions in a kind and open manner, so people feel comfortable sharing, because it matters. It affects health. Mom, like, who am I to judge? However, all I just want is this person to be able to have a healthy life. So I think like asking a little bit more about those sexual history. Because that will infer the type of testing that you want to do. And I think in this case, while also entertaining the AIDS, to be also thinking about sexually transmitted infections, thinking about like, syphilis, thinking about gonorrhea. Like we had multiple cases of disseminated gonorrhea, and something that I've learned from Robbie is like to always think about that, because it can have systemic manifestation with arthritis, with bacteremia, with rashes as well. So I think that would at least is imperative on us to rule that out and work that up a little bit more in someone who is presenting with these symptoms. And I think it was Kushal who mentioned in the chat that steroids make everybody feel better for a little while, which is like very, very, very true. So the fact that it got better a little bit with rash and then with the steroids and then comes back again, I think it just tells us that we have more work to do and to figure out. So I think that's where I am at. I would love to get a little bit more better sexual history about this patient, get some STI testing and an exam to see like if there's any other involvement whenever I think of a rash. Is it just, again, only the skin, or does it have any other organ manifestations that we have to think a little deeper about more systemic etiologies? So that's where I'm at, team. Rafa, do you want to give us some more information?
Okay, so now coming to the physical exam. His temperature is 98.7 Fahrenheit, blood pressure 126/85, and his heart rate is 85. Generally speaking, this patient is well developed, well nourished. His eyes are anerchateric conjunctiva and pearl. HEENT exam, oropharynx with irregular, shaggy white mass that looks more mass-like on exam than an ulcerated appearance. No supraclavicular, submandibular, or cervical nodes. His cardiovascular exam is normal, and his lung exam is also normal. His GI exam is also normal. And when it comes to the skin, there is this scattered, dense, dark brownish, reddish flat, densely clustered macules and patches across abdomen and chest. These lesions are also present on his back, but they are less dark, and no lesions are on palms or soles. And that's the end of the exam. Do you also want some of the initial labs?
Sure. Why not? I'm always down to have more labs.
Okay, I'm gonna give you the CBC then. So the white blood count was 6.3. The hemoglobin was 16. And the platelets were 269.
All right. Thanks so much, Rafa. Such a great case. Thanks for presenting it. How about like I'll just ask some help from the chat also and reflect on the ulcerated appearance of the mass, and I will leave the rest to the incredible RG. So I think like with any patient's vitals, like this patient is thankfully stable, so that just allows us to have more time to think about this case more stepwise, and we don't need to rush to do all the things at once, which is always good. In terms of like the white mass with the ulcerated appearance, I don't know if Ravi, if you're in a place that you can unmute, but you just put a great differential better than I have. So I would love to hear your thoughts.
A differential for the oral ulcerated mass, you mean?
Like, yeah, Ravi in the
did you call me?
Yeah.
Did you call on me? Sorry.
Yeah, we can.
Oh, okay. Sorry,
Yeah.
sometimes my name sounds like Robbie, so I don't know.
I mean, you're both very brilliant, so that's only.
Oh no. Robbie is head and shoulders way above me, so I'm always trying to log on to learn from him. Yeah, I kind of just quickly Googled and found I didn't know histoplasmosis can cause some palatal ulcerations. Then other, thinking about STDs, HPV comes up. We were talking about the oral genital form of sexual encounters that could promote that as well. So something we have to think about. Somebody was thinking about genital warts as well. But I believe in this case we don't have that issue. But CMV, hairy leukoplakia came up on a quick search. EBV, MAI can also manifest with oral lesions as well as lymphoma. I think Hans was mentioning cancerous lesions could also be in the differential diagnosis, which really can be.
Yeah. Yeah, thank you so much, Robbie, for helping me out there. I really appreciate it. And I think at the end of the day, like the question that I have is that, like, hey, is this a separated process than the other rash that is going on, or they're all connected? One possibility to think about is like, hey, is this patient has an underlying immunodeficiency and now having multiple different presentations, right? If this is a patient who was not taking his HIV prophylaxis, have an underlying diagnosis of HIV, and now is having some manifestations of that with like leukoplakia or a rash that might be a sexually transmitted infection. Or is this two processes the same that is causing this rash plus the ulcerated mass is a syphilistic type of lesion or not, is like how I'm thinking about it. I would love to hear Robbie's thoughts about maybe the generalized lash and the labs. RG.
Yeah, thank you. I'm struggling with this, quite honestly. I think if you look at if you are authentic about dermatology, it takes a 4 years of expertise to be able to come out confident looking at rashes and making diagnostic progress. And for me, I'm just not there. So I make a checklist of things that I try never to miss. And for me, when somebody has a rash, I want to make sure it's not a life-threatening drug reaction like SGSTN. I want to make sure it's not something easily treatable and actually very common like atopic dermatitis or contact dermatitis. And in that same bucket of very common, very treatable are common cutaneous dermatophyte infections like tinea corporis, tinea blank. So super life-threatening, super common. And then the other infections are actually pretty morbid in terms of spread to other people. And those are the two S's, syphilis and scabies. So there's a whole long list of infections that can, of disease processes that can infect the skin. It's no different than struggling to solve a neurology case. And so here, is this a life-threatening drug reaction? No. The extent of the skin involvement and the nature of the skin involvement makes that much less likely. Is this a common condition that is atopic dermatitis, contact dermatitis, or a tinea? And I think the answer is no, because there's mucosal involvement, so none of those are at play. Is this one of the two S's, syphilis or scabies? And the answer is yeah, maybe syphilis. Syphilis is in a patient who is at risk for sexually transmitted infections, which, by the way, we all are. Just be honest, we're all at risk of them, and there's a varying risk of depending on sexual activity. And then, so is syphilis at play? Yes. Can other sexually transmitted infections cause a rash? Absolutely. But really is the extent of the mucosal involvement that I think makes syphilis very concerning. And one fascinating thing about syphilis is that it tends to be a systemic problem. You think about what symptoms syphilis can involve. It can cause meningitis, it can cause uveitis, retinitis, oral ulcers. It can cause hepatitis, nephritis, bone lesions, skin lesions, of course, but it really tends to spare a couple of organs. And the organs it tends to spare are the lungs. And that's because syphilis hates oxygen, and the oxygen actually destroys syphilis. But the other system that tends to be spared is the hematological system. So most patients with syphilis have a normal CBC. To nerd out even more, that actually tends to be a feature of all spirochetes. So if you think of Lyme disease and syphilis, they don't tend to affect the CBC. So is the CBC consistent with syphilis? Yes. Now, a major inconsistency is the absence of lesions on the palms and soles. Most people with secondary syphilis do have lesions on their palms and soles, but they may be subtle. So where am I? Honestly, I don't know. I think I'm using the internet's brain to say, hey, this patient's at risk for sexually transmitted infections. Let's test for all of them. What sexually transmitted infection is most compatible with what we see? It's probably syphilis, but there's a hole in that hypothesis, and that hole is a lack of lesions on the palms and soles. I think the rest of this case is trying to take an inventory of the rest of the body. Is there liver involvement, kidney involvement? And as Carl was alluding to in the chat, at the end of the day, you might have to biopsy. So yeah, I think that's where I'm at. I'm there humbly recognizing the limits of my dermatological skills and leaning on Rafa to give us more information to make progress.
Okay, so let me continue with labs. The sodium was 140. The potassium was 3.7. The chloride 100. The CO2 was 31. BUN 17. Creatinine 1.09. Glucose 92. Total protein 8.1. Albumin 4.1. Globulin 4. Total bilirubin 0.9. Alk Phos 198. AST 42. ALT 50. And the CRP is 2. And this patient is HIV negative. And that's the end of the quote.
Oh yeah, we took an inventory of all the organs and we found one thing. We found that the alk phos is elevated. Is that right, Rafa? Is it high? I think 150 is my.
Let me see. Yeah, yes, it's elevated. The upper normal limit is 133, and this patient has 198.
Yeah. So there's a little bit of elevation in the alk phos. When you said the total protein, I thought there was going to be a protein gap, but actually it's not. There is no protein gap. But I was like, oh, is that what he's saying that for? So maybe I can just share how I think about an elevation in alkaline phosphatase, and then pass the mic to Charmaine to see what she has to add in terms of maybe pertinent negatives or how she's thinking about this all together. And alkaline phosphatase is an enzyme that comes from many different organs in the body. You'll hear when you're learning step 1 that it comes from the small bowel, that it comes from the bone, that comes from the small bowel, the liver, the bones, the placenta, and many other places that I've forgotten. And the reason I've forgotten them is the only times where alkaline phosphatase can be elevated is much less than where it comes from. Where it originates does not, so many sites where it originates, like the small bowel, can never cause an elevated alk phos that high without you causing other earlier problems. For example, if the small bowel is going to be the source of your elevated alk phos, your patient's in the operating room because of small bowel ischemia, so it will never happen. So what are the 3 clinically relevant sites of alkaline phosphatase elevation? It's the liver, the bone, and the placenta. The placenta comes into play in the 2nd and 3rd trimester of pregnancy, but that's not it. There's some cases where cancers can secrete the placental version of alkaline phosphatase in a paraneoplastic manner. Okay, so there's a paraneoplastic process that's called the Reagan isoenzyme that can secrete alkaline phosphatase, and the other 2 common places are the liver and the bones. And the way we differentiate that is we get a GGT. The GGT is much more specific to the liver and suggests that a component of the alkaline phosphatase is coming from the liver, but does not rule out a subclinical bony disease. For example, if you have HCC in the liver metastasizing to the bone, what you'll have is alk phos and GGT both positive. So positive GGT confirms hepatic involvement, but does not rule out bony involvement. So here the question is there a liver disease, bone disease, or is there concomitant, is there the rare association of a paraneoplastic phenomenon? I just checked my messages and I got one from Charmaine that she lost her internet connection. So I will ramble on until she comes back. Here's the problem with alk phos. The problem with alk phos is we know that this is not a hectic disease presentation. And that is an important filter. When patients are very sick and they have an alk phos elevation, they might be coming, I see that Charmaine is back. Are you back? Hello, hello.
Yep, I'm back. Sorry. I think my internet, I was like, oh my gosh, alk phos from Robbie. And then my internet crashed from all the awesome.
Well, I'll summarize. Liver, bone, placenta, all the other places can't elevate it enough. And if a GGT is positive, it confirms hepatic involvement, but does not rule out occult bony involvement. So I'll leave it at that for you to reflect on what else jumped out to you, pertinent negatives, how you're marrying this all together.
Yeah, no, I think that's all. That's awesome. Thank you so much for that teaching, Robbie. So I think like in terms of the pertinent negative of the case, so we have an oral painless ulcer, we have a generalized a rash that spares the palm and soles, and then we have an alk+ elevation that, kind of thinking about the base rate of disease, brings out a kind of more like hepatic etiology or infiltrative processes in a patient who is HIV negative. And if you look at the other labs like the albumin, the CBC, probably with this person, you're dealing with someone who has good reserve, right? Like otherwise healthy person. So I think my money is still on like getting more STI testing. I think syphilis still my leading thoughts about this patient as something that I definitely want to get an RPR and anti-trypanosome antibody to further evaluate that. I think somebody in the rash has said, like mentioned, I think it was crucial, that elevated alk+ can be seen in syphilis. I don't know if Kushal, do you want to teach us a little bit about more about that, if you're in a good place?
Yeah, sure. So I remember the case from Unremarkable Labs. They had a patient with syphilitic hepatitis with elevated alk+. The other things that I would think of with elevated alk+ would be TB and histoplasmosis as well. But yeah, I agree with Robbie that usually with secondary syphilis, you will see palmoplantar lesions as well, but this patient doesn't have any lesions there. But so far, the rash and the history, it kind of sounds like syphilis to me.
Thanks so much, Kushal. I've always learned so much from you. Thanks for sharing, friend. Yeah, I'm curious to see, Rafa, what else do you have for us?
Actually, the case ends here with an exam, but I'll make it a little bit trickier for you guys. I'm gonna tell you that this patient received a certain medication. His rash and oral mucosa lesion were, we had a resolution of those, but this patient developed a low-grade fever and chills following administration. What do you think is happening here?
Rafa, I also have a hard time pronouncing things. Is it the Gerhardt something reaction? Never learned how to pronounce that word.
Oh my God, I feel so validated right now.
That's what I'm here for, friend. That is what I'm here for.
So this patient had RPR of 1 for 128 and was diagnosed with syphilis. And he was treated with penicillin, and there was a resolution of the rash and oral mucosa lesion, but he developed a low-grade fever and chills following administration, which is consistent with that reaction that you just told us. And that's the end of the case.
Oy, oy, oy. Oy, oy, oy. I have so much to reflect on, but I'm going to be honest, okay? Mr. Shikarcha, everyone, I guarantee you, everyone at some point in this case thought of syphilis. They really did. I've met 90% of people on here, and either they thought about it or they wrote it in the chat. They did, really. So, Mr. Shikarchan, why was this case missed? Why was this case in real life treated by a dermatologist with other treatment? And that's because this is actually a very hard diagnosis to make. And I don't know. I don't know if this is true or not, but I'll speak for myself. VMR has been happening for 15 to 16 months. And before VMR, I had been working on my clinical growth since I was a third-year student for about many years. And I don't think I grew as much as a diagnostician than hanging out with this crowd and learning from this crowd and practicing with this crowd for 15 months now, to the point where all of you see this case and you're like, I wonder if this could be syphilis. And yet in real life, people who have the stamp of being an independent practitioner and actually an expert can miss this case. So what do you take away from it? I think you take away the value that hopefully somebody will demonstrate in a randomized controlled trial of deliberately practicing to improve your medical knowledge and reasoning that we are all doing right now together, but also that you don't get too cocky, because maybe the dermatologist who actually misdiagnosed this case is a member of the VMR community who just had a day where they forgot to think about this. So I think this is an amazing case. It's an amazing case because I think that with practice, you would recognize this. You see patient HIV pre-exposure prophylaxis rash. You have to think about syphilis. But here are people missing it left, right, and center. In fact, there's a New England Journal of Clinical Problem Solving case in which the diagnosis of syphilis was done after tonsillectomy. The patient had tonsillitis and they took the tonsils out and then they diagnosed syphilis. So we miss this all the time. So kudos to the VMR community for being sharper and sharper and sharper every day. And also a humble reminder that this could be you and that you could easily miss this. A personal reflection for me is just how much fun I have hanging out with this TP Solvers crew, and I've been discussing on Thursday solo, and it's not nearly half the fun as it is to hang out with Charmine, who can pronounce everything like no other, accompanied by her similar English as a first language, Rafa, whose smile and lean into the camera is just so incredibly infectious. So I will mute myself now, pass the mic to Charmine to see if any reflections. Rafa, if you learned anything from the case. Then finally, last but not least, Vale, to summarize our learning from today.
Spot on, Robbie. I feel like medicine just keeps humbling me over and over again, and I don't mind it. And I think like the power of crowdsourcing, I think that's why I just love being on teaching service. I just love VMR because I don't think medicine is an individual sport. I think the days that there was the one person, I think these things, like I do a lot better on team settings. I learn more. I think I'm a better physician when I'm surrounded by other physicians. And even if I'm on a service alone, I just like pop over to my colleagues and I ask them questions or run cases by them. Because I think at the end of the day, our goal is just for our patients to get the best care possible. And I am a better physician when I'm surrounded by other great physicians. So thank you all for making me a better doctor, hopefully. And I can't wait to learn from you, Rafa and Val.
Oh no, it's just I just want to echo Charmine. It's just a privilege to be with you guys here and learn medicine and have fun. So that's what I have to say.
Hello everyone. Sorry, my internet totally failed me and I'm on my phone. So I have some of the last teaching points here in my notebook. So I'm gonna read you what I got in the whiteboard. So we started the case with the chief concern, which was painless lesion on the oropharynx. And the first question that Shamir asked was, how was it identified? If it was painless, what was the turning point for the patient to notice it? And then Ravi mentioned an important question, which was, what about the rest of the mucocutaneous surfaces, such as the eyes, the GI, mucosa, the nose, and the skin, just to think about other differential diagnoses. And an important question that was raised in the chat was, who is this patient? The immune status on the history was at the end an important factor in considering differentials, as the patient had a sexual risk history. And then, well, early on, there was a differential in which we considered infectious, autoimmune, malignancies, vitamin deficiencies, and drug toxicities as possibilities, in which the infectious category was the broader, thinking about possibilities such as HIV, syphilis, and other STIs, also histoplasmosis, CMV, possibilities in malignancies such as lymphoma, autoimmune conditions, which Charmine mentioned that are usually painful, but important exceptions were SLE, in which there can be painless ulcers, and also possibilities as TB and Aspergillus and disseminated VZV that can also cause ulcers like this. And then the patient, as he had multiple sexual partners, well, Ravi told us about PrEP, which is a really important therapy in cases of preventing HIV infection in patients that are at high risk and has minimal drug toxicity. And crucial drop a pearl that I really liked in the chat, which was that it's really important before starting PrEP on our patients to rule out if they have already HIV, just because we will have to add another antiretroviral in the mix. And then the patient had ALK-phos elevation, but with other normal chemistry. And that fact made us think, or Ravi mentioned the sources of ALK-phos, which were placenta, bones, bile ducts, the kidney, and the SI. And mentioned also that the GGT can help us confirm hepatic involvement, but doesn't rule out bone involvement. And then we kind of thought about well, syphilis was like the first in our differential, but just some points again, the fact that the patient didn't have any palm or sole involvement, and some points in favor, the fact that the patient had a normal CDC, which was a characteristic that I really like Ravi mentioned, which was the fact that syphilis spares the lungs because it hates oxygen, and also spares the hematologic system, and can cause alphos elevation, such as other infectious causes like TB and histo. And then some pros about syphilitic hepatitis, which is that it causes alphos elevation out of proportion to other hepatic markers such as AST, ALT, and total bilirubin. And this can help us differentiate from other differential diagnoses, such as hepatitis virus that cause markers of hepatocellular injury, much out of proportion that alphos. And also another infectious causes like anaplasma that can cause thrombocytopenia and also affect the white blood count. Leptospirosis, which can cause usually an elevation of total bilirubin out of proportion to other hepatic markers. And so this was a great case. Thank you so much, Rafa, for presenting, and everyone for discussing.
Woohoo! Even no losing connections or internet troubles can stop you. Thank you so much for all the teaching points, Rafa. Thanks for presenting. Carton, thank you so much for scribing. RG, always a pleasure. And thank you everybody who contributed in the chat, and Kushal and Ravi for teaching us too. Really appreciate you all. Have a wonderful rest of your Thursday, and we'll see you soon. Bye.